Good morning. Thank you for joining us here on the first day this early. And our instruction course is Beyond Tunnel Visit, expand your understanding of visual fields to unleash its maximum potential. We have condensed visual fields into a 1-hour session, and we promise you that you will not be disappointed. For the first session, I called Dr. Jeevitha Jagatnathan to come and deliver her talk on the baseline visual fields, the criteria for diagnosis. Dr. Jeevitha has 15 years of experience in ophthalmology. She did her MS from AIOC Chennai and then the Clinical Glaucoma Fellowship at Shankara Nethralaya, Chennai, and is currently working as proprietor of NNI Care in Chennai and a senior glaucoma consultant at the Amrit Group of Hospital and a visiting consultant in several centers across Chennai. She is keenly interested in academics and has several publications and presentations to her credit. Over to you, Dr. Jeevitha. Dr. Ratni shall be moderating the session. She is a senior consultant in Shankara Nethralaya, Chennai. A note to all the attendees, if you have any queries, we'll keep it for the end of the session, and you can ask all your doubts at the end of all the sessions. Thank you.
Can you hear me?
Yeah.
Good morning, everyone. Audible?
Slightly.
Yeah. Good morning, everyone. Welcome you all to the field of glaucoma. So, perimetry is a technique of evaluating the visual field. It's a functional correlation of the neuronal loss associated with the disease. Baseline test is the test that defines the patient field status at a particular point of time, like at the beginning of the therapy or after major change in the treatment strategy or so on. It's always worthwhile to get two similar and representative baseline tests early in the course of the disease, apart from the learning curve. In order to get the best out of the visual field testing, we must be aware of what are the various testing methods, strategies, and patterns available, which tests to be done at when and how. So, Goldman size 3 is commonly used stimulus size, and Goldman size 5 has to be chosen in patients with poor vision. Central fixation target is what we commonly use, and large diamond is used in eyes with poor central vision, such as macula pathologies, and small diamond is used for foveal threshold testing. These are the various threshold strategies available. Full threshold intensively tests each testing points by double bracketing strategy. So obviously it's time taking. Whereas the CETA strategies adjust it reduces the time significantly by adjusting the intensity of the test stimuli provided based on the neighboring points intensity. And also it adjusts the testing time by it adjusts the time interval between each testing stimulus according to the patient response. This is the CETA standard. Fixation monitoring is done with blind spot monitoring, whereas in CETA Fast and Faster, it's done with the gaze tracking technology. This also helps in reducing the testing time. Full threshold takes around 15 minutes. CETA standard takes 5 to 8 minutes, and CETA Fast and Faster even more lesser. Which strategy to choose for your patient depends upon the concentrating ability and the age of the patient. And if you need more accurate information, such as if you see the patient is progressing or there is a vision loss due to glaucoma in the other eye, it's better to go for the longer test. In eyes with early glaucoma and glaucoma suspects, you can go with CETA Faster, Faster. These are the various test patterns available for testing. 24-2 is commonly used for glaucoma and 30-2 for neurological lesion, as we all know. 24-2 is just a 30-2 with this outer set of orange colored dots you see here removed. And 10-2 is concentrated on the central 10 degree of fields. Each test point is only 2 degrees apart. 10-2 is usually done in advanced field effect like this, which you see here in end-stage glaucomas. But I would like to stress a point here. 10-2 also has a role in eyes with early glaucoma, which involves the central defects. If you get to see a central defects in 24-2 like this, it's better to get a 10-2 also done. In this field, if you see, there are only 1 or 2 paracentral defects, but 10-2 shows significant depressed points. 24-2C is a newer pattern available with CETA faster in HFA3 mission. This adds an extra set of 10 points to the 24-2 strategy. It's used for screening central involvement. However, if you're suspecting central defects, better to go with the 10-2 strategy for progression analysis and all. This is a 24-2C printout. You can see central points involved. Macula program is used only when central 5 degree of the field remains. If you are looking out for a macula split, get the macula program done. What is this printout? This looks like a macula program, but if you look, this is a 24-2 done with the size 5 stimulus. So, run through of single field analysis. This is a testing pattern strategy indicated here, reliability indices, grayscale map, threshold values, numerical total and pattern deviation plot, and probability plots of the same. Here are the global indices. Down is the grace tracking of the thing. False positive is the tendency of the patient to press the button even when no stimulus is seen or when it's very unlikely to be seen. We call them as trigger happy patients. False negative is seen in inattentive patients or in patients with fatigue. Increased false negative is also associated in eyes with significant field loss, though the patient is attentive. So false positive or false negative is preferable to be less than 15%. Fixation loss is preferable to be less than 33%. Test results should not be viewed as either reliable or not reliable. Actually, you should start seeing them as a continuum from highly reliable to a marginally informative thing. Like, you should not discard the test report solely based on the reliability indices. If the reliability indices are not that great, you have to read the report with little more caution. Grayscale helps in identifying artifacts or any obvious disease-specific field patterns. It's not of much use in glaucoma. Numerical threshold sensitivity provides the raw data of actual measured threshold sensitivity of each testing points. Total deviation quantifies how much it deviates from the age-corrected normal values. Pattern deviation highlights the localized loss after correcting for any generalized depression due to media opacities. Probability map is the probability of the same defects seen in the general population of less than 5%, 2%, or so on. It highlights the subtle but statistically significant variations. Glaucoma hemifield test compares the 5 zone in the upper hemifield with the mirror image of the same 5 zones in the lower field. These zones are sensitive to glaucomatous damage. Glaucoma hemifield test usually gives an easy idea to the beginners in field interpretation. Mean deviation is the weighted average of the values presented in the total deviation plot. More negative the mean deviation value, more the defects are. Pattern standard deviation summarizes the localized loss, ignoring the generalized depression, but it follows a non-linear pattern. If you see here, it's lower in both the normal and in the perimetrically blind field, and is highest in the moderate to advanced field loss. Because of its non-linear pattern, it's not generally used in progression analysis. Visual field index is an enhancement of the mean deviation that is less affected by cataract and more sensitive to the central field defect changes. So visual field index of 100% is seen in normal eyes, and it gradually deteriorates as the glaucoma worsens. Anderson criteria is what commonly we used for diagnosing glaucoma based on the field report. In pattern standard deviation plot, three or more non-H points in case of 30-2 fields, and H points are to be included in 24-2 with P less than 5%, at least one of which is with the P value less than 1%. Pattern standard deviation less than 5%, and glaucoma hemifield test outside normal limits. If all three criteria are present, it's more suggestive of glaucoma, and if clinical diagnosis is more towards glaucoma, even one criterion is enough. These are the various staging systems available for staging glaucoma based on the field reports. Haddock Paris Anderson staging is what we are commonly familiar with, and this staging system by University of Sao Paulo includes the visual field index 2, and glaucoma staging system 2 by Brusini includes the Baby's curve of autopus. HPA staging provides a depth of overall defect thing based on the mean deviation value, the number of points involved on the pattern deviation plot, and its proximity to the central fixation. So this is a quick checklist to look into the field before diagnosing glaucoma. Look at the patient demographic, clinical picture of the patient. What is the type of test performed? Is the field reliable? Look for any abnormality. Is there any abnormality? Is it really significant? Rule out the chances of artifact. Look for any specific pattern of abnormality you see. So visual field findings have to be supported by clinical findings. If the test shows something you are not expecting, go back and look at your clinical findings again and then revalidate the test. Getting a good baseline report is important not only for diagnosis and management, but also for future monitoring. So these are my references. Thank you, everyone.
We'll take questions at the end of the session. Our next speaker for today is Dr. Divya Shetty, who's a consultant in glaucoma services, Shankar Nethralaya, Chennai. She did her MS from RIO, Chennai, and a clinical fellowship from Shankar Nethralaya. She has various papers and posters, presentations to her credit, and has won the Best Poster Award in GSI 2017. Over to Dr. Divya.
And non-visual glaucomatous fields. All visual field defects in glaucoma patients are not always glaucomatous in origin. Visual field testing is inherently prone to artifacts and errors. It depends on the subjective response to a stimulus in an artificial environment. Visual field defects could be due to any abnormality anywhere in the visual field. It is important to recognize artifacts and non-glaucomatous visual fields, whether the defects are due to glaucoma progression or not, because it influences the management, escalates medical therapy, helps in additional of laser therapy or recommend surgery. Artifacts and non-glaucomatous visual fields could be patient-related, eye-related, visual pathway-related, that is, non-glaucoma-related defects could be because of retinal disorders, optic nerve or disc abnormality, or central nervous system-related disorders. So patient-related artifacts could be due to the poor understanding of the test procedure, patient fatigue, or general health-related issues like Parkinsonism, dementia. So this is a common example of an artifact. White scotoma seen in a trigger-happy patient, where the patient responds even when the stimulus is not presented to him. So this is characterized by high false positive errors, normal total deviation with an abnormal pattern deviation, and the glaucoma hemifield test showing an abnormally high sensitivity. Clover leaf pattern is another common artifact seen due to patient fatigue. Here, the patient who is initially attentive responds well to the central testing points, and as the test progresses, because of fatigue, he would not respond for the peripheral points. So another entity called reverse clover leaf, also known as 4-dot artifact. Here, the patient misses the first 4 cardinal points, later picks up. Lens rim artifact is an artifact due to the incorrect positioning of the trial frame lens when the patient is positioned far away from the trial lens. This is an example of a lens rim artifact in a normal healthy disc where after repeating the test with the adjustment of the lens, the defects are not there. So you can see artifacts due to repeated contact procedures on the cornea, like applanation tonometer and gonioscopy just before the field test, suggested by depressed points in the paracentral area in the first field, which after repeating on another day is not seen. So in the COVID times, we have seen mask-related artifacts also, where we will see defects in the inferior field due to the mask, and after repeating the fields with the adjustment of the mask, the defects are not seen. Learning curve is another common field artifact that we see. It's a disc photograph of a 48-year-old male open-angle glaucoma patient showing inferior notch and inferior rim thinning in the right eye with corresponding nerve fiber layer defects, and similar picture in the left eye also. This was the first field done in 2023 showing defects in the superior arcuate area. The same person, after 6 months, repeat fields showing reduction in the number of the defects, though there are some superior defects in the right fields. So other eye-related artifacts are due to small pupil, media opacity, uncorrected refractive error, and ptosis. So this is a visual field test of a primary angle closure disease patient on pilocarpine. The first field is done with a pupil miotic. So as we can see, there are defects in the peripheries, but after dilatation, the visual field test is normal. Artifacts due to media opacities. This is commonly seen due to cataract or uncorrected refractive errors also. So the first visual field is showing generalized reduction in sensitivity due to cataract. Post-cataract surgery, the repeat fields are normal. So artifacts due to high refractive errors. This is seen in patients where high power trial lenses are used for correction. It's a case of a visual field of a patient with high hyperopia where the correction is plus 7.25, showing defects in the peripheries. But after the contact lens, the defects are not seen in the next field. So unrelated abnormalities causing visual field defect, this could be due to retinal disorders, myopic disc, central nervous system related. So this is a field test showing a constricted visual field in a patient with a retinal dystrophy. This is a superior arcuate defect, but on fundus examination, there is a retinochoroidal coloboma inferiorly, which is causing the visual field defect. This defect is not due to glaucoma. It's a myopic disc showing enlarged blind spot in the visual field test. This is a tilted disc causing superonasal defects in the visual field. Other optic disc disorders which can be congenital or acquired also can cause visual field defects which can mimic glaucoma. This is an example of a 26-year-old male who was started on glaucoma medication based on a suspicious disc. On examination, the right eye disc shows an optic disc pit inferiorly without any maculopathy. And the visual field test is showing enlargement of blind spot and central defects. This is another example of an optic disc disorder, optic nerve hypoplasia, which is superior segmental. An 18-year-old presented to us in 2013 with glaucoma medication started elsewhere with no record of high IOP. On examination, the right eye disc shows a superior notching with a nerve fiber layer defect, but on careful examination, there's a subtle pallor of the superior rim with a scleral halo. Visual field test in 2013 showed defects in the inferior periphery. Even after 10 years, the defects are stable. The patient had been stopped on medications, though there is no progression of the defects. So even the GOCT showed superior nerve fiber layer thinning, which was stable. So this is a rare entity which has to be kept in mind. So any young patient presenting with pallor of the superior optic disc with peripapillary scleral halo and a central retinal artery which has relatively superior entrance to the eye, this entity has to be kept in mind. So another optic disc disorder which presents with visual field defects is an optic nerve head drusen. Here in this example, there's an enlarged blind spot because of optic nerve drusen. Other optic nerve disorders which are acquired can cause visual field defects similar to glaucoma. This is a disc photograph of a 78-year-old male coming with a sudden drop in the vision in the left eye. As you can see from the disc picture, there is a pallor of the disc with some blurring of the margin superiorly, and the visual field test is showing an inferior altitudinal defect. Another example of optic nerve disorder commonly seen is toxic optic neuropathy. Here the patient had a history of treatment with tuberculosis for 6 months, and disc both eyes showing temporal pallor, and visual fields showing central defects in both eyes. This is an example of a 57-year-old female presenting with defective field of vision only in one eye with an RAPD on clinical examination. Visual field defects showing constricted fields. So MRI showed a left orbital apical meningioma causing compressive optic neuropathy. So this is a visual field test of a 21-year-old with a history of trauma showing inferior defects secondary to traumatic optic neuropathy. So other causes that can cause similar field defects like glaucoma, and this is an pie in the sky appearance in a patient with tuberculoma. So this is a 16-year-old female with both eye discs showing pallor and symmetrical defects in the inferior hemifield in both eyes. MRI brain showed periventricular leukomalacia, so the defects suggestive of hypoxic ischemic encephalopathy. So this is a case of a 75-year-old glaucoma patient presenting with visual field defects. 2015 fields were normal. 2017 when he came, he had a left homonymous hemianopia. The discs were stable in both eyes. On neuroimaging showed a infarct corresponding to the defects. Again, in 2022, there was worsening of the defects in the inferior hemifield, though the disc was stable. So repeat neuroimaging showed another infarct in the left anterior cerebellum. So any new defect appearing in a glaucoma patient without changes in the disc, always rule out other causes. So glaucoma can coexist with other conditions also. This is a 75-year-old male with right eye inferior rim thinning and subtle pallor in both eyes. So this was the fields showing superior attitudinal defect in the right eye and left eye paracentral and inferior defects. So MRI brain was normal. So this was a primary open angle glaucoma with ischemic optic neuropathy component and a left eye chronic CSR also. So glaucomatous visual field tests always respect the horizontal meridian. They are typical and expected pattern. Insert into the blind spot and structure function correlation will be there. So take-home message is it is important to recognize artifacts in visual fields, repeat fields when in doubt to avoid over-treatment. Glaucoma can coexist with other conditions also. If there is any unexplained visual field loss not corresponding with the disc, needs detailed evaluation to find the cause. Thank you.
Next speaker for today is Dr. Vidya Vadke. She's a consultant at Shankar Nethralaya, Kolkata. She did her DIPMB from Mysore and she underwent her glaucoma fellowship from Shankar Nethralaya, Chennai and was awarded the Best Outgoing Anti-Resegment Fellow. She has publications in national and international journals and has participated in various postgraduate training programs. Over to Dr. Vidya, please.
Thank you, ma'am, for the kind introduction. I welcome everyone on behalf of Shankar Nethralaya to the City of Joy. So today, the topic that we are going to discuss is structure-function correlation for glaucoma diagnosis. All roads lead to Rome. I do not have any financial interest. So this is a usual picture that we see in our glaucoma OPDs. We have a middle-aged person coming with blurring of some eye, no family history, no significant history. IOPs are on the higher sides, gonioscopy, open angles, borderline. Discs show typical glaucomatous damages. The right eye showing inferior rim thinning, the left eye showing bipolar thinning with excavation. The structural reports also correspond similarly on any structural investigation, here in this case OCT RNFL, and the visual fields correspond to inferior rim thinning showing a superior arcuate in the right eye and bipolar thinning showing a biarcuate scotoma in the left eye. But sometimes we do have unusual cases wherein we have patients who have glaucoma who present with clinical signs, in this case a 40-year-old male who is already on 4 IOP lowering agents, who has a negative history for family history of glaucoma or any other cause, any history of any nerve damage, shows a typical excavated disc, though larger in size, with bipolar thinning, slit RNFL defects, wherein structurally also it correlates. In this case, again on OCT RNFL showing bipolar thinning, wherein we expect the fields to show a very advanced damage, but when we do this, we have a generalized depression with very early arcuate scotomas, which we cannot directly correlate with the structure that we see clinically or on investigations. So this, when it happens, here we need to go back to our basics and decide why this has happened. So by definition, glaucoma is a multifactorial optic neuropathy characterized by progressive neurodegeneration of the retinal ganglion cells and a specific damage to the optic nerve with corresponding visual fields. So the implication being we are studying consequences of structural damage of the optic nerve on the visual function of the eye. The question arises, do these changes always corroborate? The answer would be no. There is discordance in the timing of detecting the longitudinal changes in the optic nerve disc and the visual field. The very existence of the entity called pre-perimetric glaucoma is an evidence to this, because pre-perimetric meaning the disease has been detected on a structural investigation, but it is yet to appear on a functional investigation, as in this patient. Why does this happen? So today let's go into depth about this. First of all, we should be clear that we are studying surrogates. When we say structure function, ideally we should be studying the structure of the RGC as a cell, cellular level, intracellular imaging. And when we say function, we should be studying the electrophysiology of the individual cells. But what we study is something else, because in vivo, these tests would not be possible. So when we study structure surrogates like rim area, cup volume, retinal nerve fiber layer thickness, and other things. And when we study function, instead of the electrophysiology, we are studying mean sensitivity, mean deviation, and individual point sensitivity on perimetric and psychophysical tests. Also, when we study these surrogates, we have our scaling differences. Not that both are studied in linear units. Structure is studied in linear units. Functional data, which is in perimetry, visual field sensitivity is recorded in logarithmic units. So when using logarithmic units, we have to keep in mind that they are non-linear. Decibels are non-linear measure where a change of 3 decibel represents a doubling or halving of the light intensity. This nature, the logarithmic unit, gives rise to a concept called functional reserve, wherein in the early POAG, we feel that the structural loss appears greater than the functional loss. In more advanced diseases, it appears as if the function changes more than the structure, but this is actually because of the curvilinear relationship of the structure and function because of the change in scales. Also, another reason why we have discordance in visual and in structure and function is the eccentricity of retinal location. So to produce a similar functional change, a greater number of retinal ganglion cells must be lost in central retinal area as compared to the peripheral areas. So in the central 15 degrees, the relationship is likely to remain nonlinear because of the spatial summation effects. The axons of the retinal ganglion cells, they summit. But outside the central 15 degree, a linear relationship is maintained. So this change of the location of eccentricity adds to the discordance. Also, as every human being is unique, every optic nerve inserts in a unique way. So there is anatomical variability, which is a major source of imprecision. Selection bias, when we decide to study structure function, what we are going to select is we are going to select patients with glaucoma whom we understand that have a structural damage or functional damage. Sometimes in studies, even patients with ocular hypertension and all are included. But before we even understand the concept, there are some cases which are not selected in the study because they do not fit in the criteria. So there is selection bias, and which will bias the outcome of comparisons. There definitely exists anchoring bias in the field of glaucoma because we have a lot of data, but there is still a lot of things unknown. So studies which also elect to include normal subjects and ocular hypertension also add to the anchoring bias. Statistical methods, again, whichever method we are using has its advantages, disadvantages, and that can add to the structure function correlation and non-correlation. As with any investigation, any test, there is test-retest variability. Both visual field and structural measurements are subject to variability. The sources being poor image quality, lens opacity, cylindrical error, poor visual acuity, low analysis confidence, and others. Now this variability also gives rise to some diseases like red disease, wherein there are false positives. That is, a normal is labeled as abnormal, like in this case where a myopic eye was labeled as glaucomatous because of the normative database applied to the extremely refractive error eye. And there is something called as green disease where normal is labeled as abnormal, where abnormal is labeled as normal. So in this case, a patient of known glaucoma having an inferior rim notch, when presented with CRVO, had retinal edema, and because of which the GOCT showed a green image showing normal thickness in all, which is actually false. Again, sampling pattern of the points to be studied affect the structure function correlation. 50% of the retinal ganglion cells are found in the central 20 degree of retina, but only 12 points, that is 22% of the points, lie in this region. There are many other variables depending on what kind of RGCs are affected, what kind of RGCs we are studying, and what stage of the study is, stage of the disease is being tested, and the heterogeneity of selectivity and damage among glaucoma patients. When we decide to study structure function, the first map that comes to our mind is the Garvey-Heath map, who have tried to correlate the different sectors of the optic nerve to the corresponding points on the visual field. The question remains, which comes first? So it is equivocal as to whether the earliest signs of damage are anatomical or functional, and this will be limited to the detection capacity of the investigations that we use, and it will keep changing depending on the different investigations that keep coming up in the near future. The limitation of automated perimetry in the early diagnosis of POAG has definitely a clinical significance because both results of OSTS and EMGT indicated that early diagnosis has a good prognosis. But in case of SAP, it is not the case. At least 25 to 35% RGC loss is needed before we can detect functional loss in the standard perimetry. Now, having said all that, it might sound disappointing that the structure-function correlation does not happen in each case, but nothing to get disheartened. We can use this disagreement at our benefit. It is not to be confused with a poor predictive value. Predictive ability is there, just agreement is not there. So how can we use this to our advantage? We can use it to improve the chances of detecting progressive changes over time, and we can integrate both structural and functional results for a better outcome. So we have a beautiful staging system given by Brusini et al., which integrates the structural and functional correlation so that we can stage the disease better and treat it better. Also, a combined structure function index has been proposed, which helps us to differentiate the different stages of glaucoma, which uses the number of RGCs damaged and the number of RGCs expected to be damaged and gives us an integrated index, which has a better prognostic value. Also, Zeiss Forum, no financial interest, has this combined integrated assessment in its system where it integrates the functional and structural test in the same printout where we can assess both of them together and have a better picture of the disease. Application of Bayesian model, which Bayesian statistics based on the prior beliefs and which integrate the newer findings, also integrate both structural and functional data concurrently and make our prediction more accurate of the damage we are expecting and for us to take steps well in time. Further steps which can be taken are detection of early ganglion cells by perimetry, which we can improve by linearization of the structure and function data, which we earlier discussed is not linear. We can linearize it, but then it needs clinical feasibility, which is yet to be done. Now, any talk would be incomplete without mention of AI. So AI to the aid, when we are comparing structure function, there have been attempts made to develop AI-based structure function map relating to RNFL damage to functional loss. So here we have the top one, the actual field defect of the patient, having OCT RNFL thinning shown in the left side picture, and the AI has generated a similar field defect inferiorly. So in a nutshell, structure and function should be monitored closely in glaucomatous eyes and to decide the type of investigation and the frequency of investigation based on the progression based on these investigations. And we should correlate structure, function, but not just these two, clinical findings and patient's quality of life to make a clinical decision about investigation and the further interventions. Thank you so much.
Thank you, Dr. Vidya. I invite Dr. Reni, Senior Consultant in Glaucoma Services, and she did her long-term fellowship in Shankara Nethralaya, Chennai, has several publications to her credit, including chapters in books. She has also won the Best Paper Award at GSI twice in 2014 and 22. And her clinical skills and approachable nature has made her a go-to person for all glaucoma trainees during and even post-fellowship. Over to you, ma'am.
Good morning, one and all. My topic for today is the ups and downs, progression or fluctuation, mastering the glaucoma progression analysis. Estimation of threshold sensitivity in visual field testing is not perfectly repeatable and it's often affected by variability. Variability is often a confounder of progression. So coming on to a bit of a background where you have to know a certain terminology like the noise, which is a physiologic background noise in the visual system against which a stimulus signal may be detectable, is quite variable, causing threshold variability. The factors causing noise are neural noise, cognitive function, decision criteria, and threshold strategy. Other factors which can affect threshold sensitivity are the overall degree of visual field damage, the degree of damage at a particular location, and the eccentricity of the particular testing location. So how can we quantify this variable? Intensive sensitive psychophysical tests have been conducted and the frequency of seeing curve has been plotted. The points along this frequency of seeing curve at which 50% of the stimulus are detected represents an accurate measure of the threshold, with the slope providing a measure of the intra-test variability. So steep slopes signify low intra-test variability and shallow slopes signify greater variability. Eyes with advanced glaucoma show greater variation, which may not be due to fixation errors, but may be mostly due to atypical firing characteristics, damaged retinal ganglion cells, and a lower ganglion cell density. Other ways of quantifying variability would be the long-term and short-term and long-term fluctuation. Short-term fluctuation is a simple global index which is derived from multiple threshold estimates made during a single test, and it's a clinical equivalent of intra-test variability. Long-term fluctuation is calculated mathematically from multiple visual field examination. It's not available on a commercial instrument, and it is a clinical equivalent of an inter-test variability. Another alternative method of quantifying variability is the test-retest variability. It quantifies the scatter of measures made on one or more examination at different test locations. So variability, unlike the psychophysical test, variability can also be investigated based on data gathered with test strategies designed for rapid estimation of threshold, which is suitable in clinical environments. So variability may occur due to instrument design and thresholding strategy. For example, if we take full threshold versus fastback strategy, we find that the full threshold tends to exhibit lower variance than the fastback because of its Ripple criteria. A size 5 stimulus also would exhibit lesser variation. So what is progression then? The defects must be repeatable and reproducible in the same location, and it must exceed the test-retest variability. So coming on to a little about the rate of progression. An average rate of progression visual field in a treated glaucoma patient would range between minus 0.05 decibels per year to about minus 0.6 decibels per year. And the rate of loss due to age would be accounted by minus 0.06 decibels per year. For a past progressor would typically exceed more than minus 2 decibels per year. So according to Chow et al., they found that to detect a decibel change of minus 1 mean deviation, we have to at least do 7 fields in 2 years to pick up progression earlier. The EGS and the World Glaucoma Association consensus also recommend 3 visual fields per year, including the 2 baselines, so at least 6 fields in 2 years. So the progression analysis can be done non-statistically and statistically. Non-statistically would be by clinical judgment, and statistically by defect classification system, event and trend analysis. So coming on to clinical judgment, it consists of a simple subjective observation of sequential visual field tests. So the advantage of it being it's easy to perform, no additional commutations, and it's quite flexible. Disadvantage is that it's subjective, non-statistical, and non-standardized. According to Vishwanathan et al., they found that when 5 expert clinicians graded 27 visual fields with no guidelines, only based on the perimetric output, there was a fair inter-observer agreement with a kappa value of 0.32. The overview report makes it simpler, puts together all the patient's available visual field into a single report. The overview printout represents the grayscale, the decibel sensitivity value, the global indices, and total and pattern deviation plots across a series of visual fields. So this is an example of an overview printout, which gives you all the visual fields in one look. This is another example in which patient had a cataract, so you can see the depressed total deviation and the pattern deviation, and after cataract surgery you can see that all these defects have disappeared in the last report. So defining progression. So the early manifest glaucoma trial defined visual field progression as significant change from baseline on at least 3 locations on 3 consecutive visual fields. This criteria is a glaucoma change probability, and these criteria has been incorporated into the GPA. The other systems of classification are based on the Advanced Glaucoma Intervention Study and the Collaborative Initial Glaucoma Treatment Study, where there is a scoring system between 0 and 20, 0 being normal and 20 being the worst field status. They were both based on total deviation maps. The EMGT criteria definitely detects progression on an average of 1 year earlier than the other 2 criteria, and there is only a fair to moderate agreement among these criteria and clinical assessment. So coming on to event and trend analysis. The event analysis compares all points on the visual fields to 2 baseline visual fields to assess if progression is present or not. So the GPA compares each consecutive test to the baseline point by point to find any deviation beyond 95% confidence interval for expected test-retest variability. The GPA uses the same criteria used to define progression in the EMGT study. So selection of baseline is very important. 2 baselines which are reliable have to be chosen which have been done within 6 months. And it's also important to remember to change the baseline following any intervention performed. The GPA performs a progression analysis probability plot where it compares the baselines with the current visual fields and gives you a probability plot with a small open triangle indicating a degree of deterioration expected less than 5% of the time at that location. A half-full triangle indicates significant deterioration at that point in 2 consecutive tests, and a solid triangle indicates significant deterioration at the time in 3 consecutive tests. And X signifies that the data at that point was out of range for analysis. So it also gives you a GPA alert. So the possible progression is when 3 same points show worsening in 2 consecutive tests, and likely progression when the same 3 points show worsening in 3 consecutive exams. So Arnalik, Monitel et al. Said they found that the possible progression criteria achieved a sensitivity and specificity of 93 and 95% respectively, and a positive likelihood ratio of 20% based on a thorough objective clinical assessment. The advantages of the GPA, it is not greatly affected by media opacities and refractive errors. The disadvantage being that it is difficult to identify progression in patients of glaucoma with diffuse loss, and its usefulness is also limited in advanced glaucoma when it's severely depressed beyond minus 15 to 20 decibels. And an additional software is of course required. The Forum CS software allows access to visual field data from multiple HFM devices. Visual field index, as we've already been talked about earlier, it is mostly based on pattern standard deviation and it's more center weighted. However, in advanced visual field loss, the total deviation values are used instead of the pattern deviation values. So in trend analysis is a linear regression analysis of global indices such as VFI and mean deviation. In GPA2 performs a linear regression analysis of VFI over time. So at least 5 to 6 visual fields over 5 years is required to achieve a good performance. It also gives you a slope of regression with the whether it is significant or not with a 95% confidence interval. So you can see here. So this is a regression analysis that has been done, which shows the current amount of visual function of the patient, and it also gives you the prediction of the VFI for the next 5 years. And this is the estimated rate of change. So the GPA2 in the Humphrey visual field is the most commonly used progression software. GPA2 provides both event and trend analysis. It supports strategies like CETA standard and CETA fast and programs such as 24-2, 30-2, but not 10-2. So this is how a full summary looks like. So you can see the 2 reliable baselines followed by the VFI regression analysis with the rate of progression. Then you have the present visual field progression analysis, and with the GPA alert at the bottom. So Casas, Lera et al. Found that GPA2 detected progression in 16% in which trend analysis had failed, and detected progression 6 to 8 months earlier than visual field index. So these are few examples in which you can see that both the event and the trend analysis are fairly stable over time. And this is another example where you can see slow progression occurring in the trend analysis and also in the event. So this is another example where the trend is stable, but however the event is showing some a likely progression. This is another case where both the trend and the event are progressing. In this is also you find both the trend and the event progressing. So another way of assessing progression would be to do trend analysis by using clusters. So Crab et al. Proposed a wait-and-see approach in which visual fields were clustered at baseline, then again at the end of 2 years, based on computer simulations. Improved detection of progression. It is definitely improved detection of progression than testing at regular variables, and it also reduced the false positive rates. The logic behind it is that the data near the beginning and the end may influence a trend analysis more than doing it at regular intervals. So how do we assess progression on 10-2? So we know that the central vision is affected early in glaucoma, and that it is not so uncommon, which can ultimately affect the macular function and the quality of life. Currently, there is no available commercial software for detecting progression in 10-2. T. Morris et al. Developed and validated a set of criteria that uses point-wise linear regression analysis of the threshold sensitivity data to detect progression. Park et al. Also retrospectively studied 50 eyes with parafoveal scotoma with longitudinal 10-2 and 24-2 perimeters using pointwise linear regression and detected progression in 24 eyes with 10-2 visual fields. And among these, progression was missed in 17 eyes using the 24-2 visual fields. So take-home message, detecting progression still remains crucial for glaucoma management, and it's also an important for us to decide on stepping up treatment. No single method may be absolutely reliable, and lack of gold standard is a major disadvantage. With the GPA, in short, the event analysis may alert the clinician of the onset of a change, and the trend analysis assesses the rate of change. Thank you.
Thank you, ma'am. Invite Dr. Kiran for this session. He's a consultant in glaucoma and anterior segment in Precise Specialty Eye Care. He did his MD ophthalmology from RP Center AIMS.
Change your time.
And he graduated as a best resident. He continued there as a senior resident in glaucoma and cornea. He has conducted several talks and been part of the organizing committee of several state as well as national conference. Over to you, sir.
Can you change the time to 12 minutes? My talk is for 12 minutes.
The time is 12 minutes. Please reset the timer to 12.
Set the timer to 12, please. Okay, welcome everyone. The focus of my presentation would be the octopus perimeter, and we will try and look at the various differences between the more widely used Humphrey perimeter and also discuss the pros and cons. It's not moving. Okay, the octopus was actually the first automated perimeter that came in 1974. The Humphrey came almost a decade later. The most widely used model of octopus is the Octopus 600, which is on the left of your screen there. You can see that it's not a cupola-based perimeter like the Humphrey. This is a screen-based perimeter where the patient looks into a screen through those rings which I have marked in the photograph. Now, from the machine perspective, there are some advantages, like this can be operated under daylight conditions, and that it's a silent perimeter, doesn't have the motors of the Humphrey, which can be distracting for some patient. Now, you can feel that the absence of a liquid trial lens like you have in the HFA3 can be a disadvantage because it helps in faster setting up times. Now, with the Octopus, nobody actually looks at the printout. You have the iSuite software that is installed on your desktop. So through single clicks, you can get any kind of representations you want, whether it is 7-in-1, 9-in-1, 4-in-1. You can, just single clicks are required. But for easy understanding, I have just used a baseline of a 7-in-1 representation of a patient for simply easier understanding. Let's start with the examination parameters. You notice that I have here used the 24-2 pattern. This is basically for the sake of continuity. But the Octopus does give you the advantages of having some optimized patterns for glaucoma, like for example the G pattern. You see that the G pattern points are more in the central and the paracentral area. And also the distance between the points are not equidistant. As you move away towards the periphery, the distance increases. The closest equivalent would be the 24-2 C pattern of the Humphrey, which was already described, where 10 extra central points are tested. Let's look at an example here of a patient where 24-2 pattern is done. Only a couple of abnormal points here, which you probably dismiss that as normal. But the same patient's G pattern is immediately picking up a cluster of points in the center. The patient does have an infratemporal RNFL defect and inferior thinning, thus helping us to pick up a diagnosis of glaucoma earlier with the G pattern. Similarly, for the 10-2, you have the M pattern, which again tests more points in the center. Now, if you look at the test strategy, I have employed in this particular patient the top strategy, and you also notice that the time taken is 1 minute 33 seconds. So this is in terms of time taken equivalent to the Sita faster. But unlike the Sita faster, this also tests fixation and also tracks false negative errors. Unlike the Sita faster strategy, the equivalent to the Sita standard would be the dynamic strategy. Now, I'm not going to the details of false positives, negatives are all same as the Humphrey, but fixation control is something that I think merits a mention here in Octopus. The Octopus has so many methods of fixation control. It tracks pupil, dart, automated eye tracking, blink, and contact. What this essentially means is that if the patient is feeling fatigued, he can simply close his eyes. The machine will automatically stop, and once he opens, the machine will restart. This is why a lot of people who have unreliable results on Humphrey can get actually reliable results on the Octopus. Now we look at the representations. Most of these representations are simply differences in terminology. There are some only minor differences. Now the values representation is the same as the threshold values on the Humphrey. There is no difference at all here. Comparisons is the same as the total deviation numerical map. But one difference in representation, you will see a lot of plus signs here. Now those plus signs are points where there is a sensitivity loss of less than 5 decibels. They're not very important. I feel this is a better representation because immediately looking at the comparisons, you know the pattern and the shape of the defect, because all the numerical values indicates that there is a defect there. Now the grayscale in the Octopus is different in two aspects. One is obvious, it's a color scale rather than a grayscale, it's color coded. The other difference is that the grayscale on the Humphrey is based on the threshold values, whereas this is based on the comparisons of the total deviation. So this actually has greater value. Now, if you look at the probabilities plot, it's the same as the probability, total deviation probability map in the Humphrey. And similarly, corrected comparisons and the corrected probabilities are essentially the same as the pattern deviation numerical map and the pattern deviation probability maps. But what is unique to the Octopus representation is something called a defect curve. I'm not going to the technical details of how this is plotted, but a normal defect curve will lie between those two parallel lines as shown in the figure. And if the patient has a diffuse defect, the curve will shift downwards in a parallel manner. And if you have a local defect, it will drop towards the right, and both will happen in a combination of local and diffuse defects. There are other patterns for hemianopy as well, but this is essentially a snapshot. One quick look at the defect curve, you know whether this is a local or a diffuse progression. Now, if you look at the indices, there are 5 indices. The one at the bottom is MS. That's not very important. Let's look at the important ones. The MD, or the mean defect, is similar to the mean deviation, representing both local and diffuse loss. The square root of loss variance is again similar to the pattern standard deviation of the Humphrey and represents local loss. The 2 other indices which are unique to the Octopus called the diffuse defect index and the local defect index. Now these are calculated from the defect curve I showed earlier, and that is why they are unique to the Octopus and represents diffuse loss and local loss respectively. Now, the 9-in-1 representation of the Octopus has 2 other features. One is called the cluster analysis and the other is the polar analysis, which are unique to the Octopus. Now, cluster analysis is very sensitive for early defects. It basically divides the entire visual field into 10 different clusters based on the patterns of the RNFL bundles. Let's understand this with an example. If you look at this patient's left eye visual field and you look at the corrected probabilities, let's look at it in a zoomed up manner. There are only 2 abnormal points as per the criteria described. You dismiss this as normal. But the cluster defect analysis shows the significant cluster defect in that particular region. As you can see, it's color-coded also for easy understanding. And the patient does have a supratemporal defect that will correspond to the cluster defect in that patient, again replicated on the OCT as well, thus helping us to diagnose glaucoma at an earlier stage with the cluster analysis. The polar analysis is a kind of a software trickery to give you some function structure correlation as well. It helps you to identify where you want to look for the changes in the optic disc. Based on this principle, let's look at that point in the visual field with 13 decibel sensitivity loss. Obviously, that will have a corresponding representation in the optic disc. So if you look at our base patient and you look at the polar analysis, you see those long red bars in the infratemporal region. That is where you want to look for the optic disc changes. The newer software also gives an ONH projection analysis through a single click on your computer, and that will also tell you that it's the infratemporal region. That is where you want to look for, and exactly that is where you find the defect. There's a large infratemporal defect. That is the beauty of the polar analysis. And the Octopus does have an HFA style printout also for easier transition. For people who wants to transition to the Octopus, it's the same printout will be given in the HFA style. So the terminologies will now be the same as the Humphrey, which is for easier understanding, but it will lack all the unique features of Octopus. It will not have the defect curve, the cluster analysis, the polar analysis, all the extra indices that you get. But if you look at, therefore, a single field analysis, all I can think of are actually pros, because you have more optimized patterns like the G and M pattern. You have a cluster analysis, which is again very sensitive to detect early defects. The polar analysis and the ONH projection gives you function structure correlation. The defect curve snapshot, you look at the defect curve, identify what kind of a defect the patient has. Everything is more color coded, and I feel it's better aesthetically also. And you have the HFA style printout also for easier transition. So these are the advantages. I couldn't find a single con as far as the single field analysis is concerned. Coming on to the progression analysis. So this is how a representation of the progression analysis looks like. So on the bottom you have the color scale of all the, an overview of all the color scale of the fields which you have used for progression. And then the trend analysis of the 4 indices which we have already described. And then you have on the top right cluster trend analysis and the polar trend analysis on the bottom right. So if you look at the trend analysis, again, all the trend lines are color coded. If you see there, except the diffuse defect, all the 3 other indices are coded red. That immediately tells you that this is actually worsening. And also, apart from the color coded trend lines, you have those patterns which I have marked there, for example, that tells you if it's worsening at p less than 5 or p less than 1. Again, so intuitive to understand just by looking at it. Now, also, depending on the indices worsening, you can make a distinction between local and diffuse progression. For example, if it's a diffuse progression, you will have a change in the MD and the DD trend lines. And the local progression will have a change in everything except the diffuse defect. And with diffuse and local, you will have both. Now, you also have now the cluster and the corrected cluster trend analysis. This is helpful for detecting subtle localized field change, and also, unlike the trend lines, it starts giving you spatial information of where this is happening. So this is our base patient example. You can see that it is the 3 supranasal cluster area that is actually worsening in this particular patient, and the color coding is again pretty clear. The inverted red triangles tell you that it's actually worsening in those areas. This does not really require an explanation. You immediately look at it, you understand this is where it is worsening. Now, the polar trend analysis and the ONH trend analysis again links functional progression to structural progression. Again, from our base example, does not require any explanation. The infratemporal region, you can see those long red areas. That is where the progression is happening. The projection trend analysis also shows those 3 inverted red triangles, telling you it's that area of the patient's optic disc that is undergoing the progressive changes. To summarize the progression, so you have the collection of the fields, which is the color scale of comparisons, which is again very important. From that itself, you can understand that, okay, it's in that area, the supranasal area, which is actually showing the progressive worsening. The trend analysis immediately tells you that apart from the diffuse defect, all the 3 other indices are worsening. So this has to be a local progression, right? The diffuse defect is not remaining the same. Now, the cluster trend analysis tells you that, okay, it is those areas which is actually worsening, those 3 supranasal areas. And the polar trend analysis and the ONH projection trend analysis tells you that in the infratemporal region of the optic disc, you are going to face the progression in this particular patient. Now, if you compare the IC394 versus the GPA, there are some advantages versus disadvantages. First of all, an advantage is that it's more comprehensive trend analysis. The GPA gives you the visual field index only. This gives you all the 4 indices. Now, the polar trend analysis again gives you a function structure correlation, which is pretty unique. If you notice, the octopus employs only trend analysis. Now, one could argue that this is more resistant to more outliers, which you get in your clinical practice very often. The first 2 fields may be wrong, then the 5th field may be completely out of whack. So this is more resistant to outliers, but that is where one disadvantage also comes. The IC394 software in general is also, as you notice, is color-coded, it's easier and more intuitive to understand. But the difference is there is no point-to-point event analysis. Right? But the GPA has a lot of pedigree also because it is derived from the EMGT. And the point-to-point event analysis is considered to be very sensitive for early detection, as has already been mentioned by Dr. Reni. And therefore, that can be considered as a con. I thank you for your patient listening.
The last speaker for today is Dr.Reni Philip, who is currently working as a consultant in Shankar Nethralaya, Chennai. She did her MS from Kottayam, and she's a trained research and clinical fellow from Shankar Nethralaya, and she's awarded the best outgoing fellow as well. She has several publications in various regional, national, and international journals, and she's also a prestigious contributor to the Shields textbook of glaucoma, South Asian edition. Over to you, Dr. Reni.
Thank you, ma'am. Good morning. Now that you've heard about the common techniques of fields, the octopus, and the Humphrey, let us take a look at what other visual field modalities we have currently and in development. So we have come a long way from the time when Ptolemy first noticed the circular form of visual fields way back in 150 BC. And along with octopus, Humphrey, we also have shortwave automated perimetry, FTPs, virtual reality head-mounted perimeters, tablet perimeters, fundus projection perimeters, and eye movement or eye gaze tracker perimeters, and a lot of advances in AI, home monitoring, etc. that is going on. So we sometimes wonder whether these are as good as the established ones and what their current status is and scope for future development. We definitely would have an advantage having an alternate visual field technique that is helps in earlier diagnosis, is more accurate, accessible, and has a larger coverage, and can be used by the patient themselves easily. So these are a few of the devices that are available, as well as those in the pipeline. Due to time constraint, I shall restrict myself to one per category of the established devices. So shortwave automated perimetry uses a blue stimulus on a yellow background, as you can see here, when compared to the white-on-white perimetry. It is the S-cones are largely unaffected, and it's available on both the Humphrey and octopus. Though it's supposed to detect glaucoma earlier, this is a printout of the SWAP. You can see the SWAP mean deviation and of abnormal glaucoma hemifield test. And the OCT shows a normal RNFL. And this is the same patient, CETA standard, a year later. SWAP is, however, no longer recommended for glaucoma management because long-term follow-up studies have shown that the white-on-white stimulus detects as much a more field loss in glaucoma as SWAP, and also at least as early. Additionally, SWAP also has a few inherent problems with respect to nuclear cataracts, which act as blue filter, the time, and its limited dynamic range. The fundus projection perimetry, the compass, is designed with a scanning laser ophthalmoscope that is combined with an automated perimeter and can present the light stimuli compensated for the eye movements through the fundus tracker precisely on the area of the retina that needs to be tested. So this is the interface while doing the test. You can see a green circle here, that is the retinal tracker, and these points show where it has been projected. You also can monitor the pupil and the number of points that have been completed. So you can see here, if you're not able to see the fundus, the machine stops, such as if the patient goes back, the tracking is on hold. And the report shows, in addition to the projection and the sensitivities, which is reverse of what is there in the fields printout, because it shows exactly where it is projected in the retina. You also have the staging system. And one thing to note is, instead of the VFI, we have the fundus perimetry deviation index from 0 to 100, where central points are more heavily weighted. And also that there's a fixation plot, but even if you have defects on that, it is not an indicator of the reliability of the test, as the machine corrects for the eye movements while projecting the stimulus, so that it does not necessarily degrade the test reliability. Progression analysis is also available, both the mean deviation as well as the FPDI, and cluster is also available on progression. There is good agreement between mean deviation in COMPASS and HFA, and the test retest variability was better than for HFA, and the testing times were similar. So frequency doubling perimeter is a portable perimeter that tests the ganglion cells along the magnocellular pathway, which is selective for glaucoma, and the tests are very fast, such that the suprathreshold testing can be even less than 1 minute per eye. This can be used in normal room lighting and is not affected by pupil size, and has an extensive normative database. The newer models, the Humphrey matrix, presents the reports in a 24-2 pattern with a stimulus size that is smaller than the Humphrey FTT 710, and also has connectivity to EMR and Forum. So the Humphrey matrix is faster than the CETA standard and has good agreement correlation between the mean and pattern standard deviation, but there is poor agreement with the glaucoma hemifield test of the two instruments. The head-mounted devices, ELISAR is a representative advanced vision analyzer. It has 4 components, that is the head-mounted device, a patient response button, the controller device, and a back-end cloud server. The display system consists of a liquid crystal display. You have a Goldman size 3 stimulus, and test strategies include 10-2, 24-2, 30-2. It takes around 6 to 8 minutes, and eye tracking is present. This is a report on the AVA, and you can see that it says a low test reliability is there. One thing to note is that this printout shows a picture of how the patient's field is, so that they can understand. This is helpful for the patient. But you see, these 2 reports are taken on the same patient on the same day, and you can see that the glaucoma CETA shows it's normal, whereas this is unreliable and showing that there are defects. This is similarly another patient's report. The mean test duration was found to be similar, but the normative data is fairly less when compared to the CETA normative data. In addition, when you look overall at all the head-mounted devices, the range of contrast, a lack of normative data, and lack of progression data, and in some devices, the test duration is also longer compared to the Humphrey. So these are all areas where they should improve. The tablet perimeter, an example is the Melbourne rapid fields, where this is the fixation target, and white or gray spots come in the periphery, and the patient can tap at the touch zone. Depending on the size, the fixation may be in the center or in the periphery, and the patient can respond. There are 2 strategies. One is a radial orientation assessing 66 locations, and the other is like the 24-2 grid. These are examples of a normal eye, mild glaucoma, moderate, and severe glaucoma patients with the Melbourne rapid fields. There is a strong agreement between MRF and HFA for mean and pattern deviation. And progression data is available for a very small group of patients, where patients were asked to do weekly Melbourne rapid fields and a total of 5 to 6 fields of Humphrey. It was found that Melbourne rapid fields were less reliable than Humphrey, but the promising part is that the HFA GP analysis gave little bias from the MRF slopes. So, areas for alternative visual field technology to improve is in the sensitivity in early glaucoma, the measurement of progression, and evaluation of advanced glaucoma, standardization of testing environment, the normative database, and we also need more validated results with adequate sample population. Currently, you can consider them for use in screening or use as an alternative in elderly patients, inaccessible patients, and in remote areas without access to standard automated perimeter. In future, we can hope for a system where fields are as easy as just sitting on a couch and doing it, with improvement of the existing devices. And in the pipeline, we also have eye movement or gaze tracker perimetry, home monitoring devices, and there is AI prediction of individuals at high risk of progression. Thank you. We shall now take questions, if anyone has any queries. Madam, what would you like to say about the macular versus the 10-2 program? Do you recommend doing the macular program now that you have the 10-2 available?
Earlier, only the macular threshold was done, but now with the availability of the 10-2, that is preferred because it has it tests a central 10 degrees and it has more test points, and so it gives us more information rather than the macular threshold. How frequently is the 24-2C done in clinical practice? Dr. Chivita, would you like to take the question?
Actually, can be used in a general ophthalmology setup if you're expecting some central involvement. Like routine glaucoma practice, I think we do 24-2. If we see central effects, we go for a 10-2. It can be used for screening purposes in a general practice setup.
Yeah, when you want to save time and...
In order to save time and patient can't do 2 tests.
Yes.
If you're just looking for a screening, if a patient comes with the family history of glaucoma or you suspect glaucoma suspects, those cases it can help.
in more advanced cases, you would definitely
if
do...
the definitive glaucoma clinical picture is suggestive of glaucoma, then I would go for 24-2 with the 10-2 if needed. Thank you.
What's the disadvantage of doing the 24-2C? Why would you not do it?
Sir, 10-2 will give you more information,
No, but
sir.
when you when a patient is coming for the first time, you are suspecting something in
Yes,
a
sir.
clinical examination. So what would you order now, 24-2 or 24-2C? That's what I want.
If you have a suspicion, yes, a 24-2C, and if that shows something up, then maybe a more detailed 10-2.
I just wanted to know because over the last 1 year or so, I've almost completely shifted to the octopus. For all new patients, we perform the G patterns. Whereas, for continuity, if you have old 24-2 patterns of the Humphrey, then obviously we want to do the 24-2 for easier, tracking of the patient. So for a default person, for the first test, do you still do 24-2 or 24-2C?
24-2 as a routine is what we do, sir.
Okay. And what about?
Unless if there's a suspicion,
Okay.
then we order for a 24-2C. But mostly it's only a 24-2 that we ask for.
Okay. Thank you.
So the GCC shows any changes? Is it always followed up with the 10-2 visual fields? The structural changes are there in the macular scan. Dr. Vidya, would you like to take that question?
Ma'am, actually functional tests are the one that we do primarily. So primarily if the central defects are there. GCC, we do structural test not routinely because for the cost effectiveness, but only if I have a patient say pre-perimetric where I suspect, where I don't even get a point on 10-2, then that I will correlate, get it documented on a GCC. And then 6 months, 8 months, we will follow it up with both GCC and 10-2 to see whether the points are coming up on the 10-2 with treatment.
Any other questions from the audience?
Thank you, everybody. We should end the session.
Thank you. This steps here, no?